change.
All right. Well, good morning, everybody, and welcome to International Renal Rounds. Looks like we have a few people around. We even have the man himself, Dr. Larry Cargill, in the place. It's nice. Um, so, as usual for International Renal Rounds, we wish that it's more like of an open discussion. We wish that you bring your question, your cases, um, before me and myself start rambling on some like random topics. So if anybody wants to take the floor and maybe bring a case or bring some particular questions about extracorporeal therapies, I will be happy to take them. And that's usually when we get crickets.
This seems all familiar to me.
Yeah, right? Okay. So I was kind of expecting that, so I actually did not come unprepared today. And I wanted to introduce that topic because it's something that actually I never really thought about so much until recently. One of our colleagues doing extracorporeal therapy sent me an email about how I would get my samples pre and post filter or my effluent sample to look at urea kinetics during a treatment. And that colleague was using the carpe diem, which is not very familiar with. But his main problem there is that he felt like the results he was getting for pre and post filter BUN or effluent BUN just did not make sense. To the extent that even sometimes the post filter BUN would be higher than the pre filter BUN, while it still had some BUN in the effluent. So it kind of looked like spontaneous generation of urea within the circuit, which obviously is not possible. So I don't really have a good explanation for that, but it reminded me of a paper that came out probably a year or two ago that I briefly read, and I started to go back to look for that paper because I think it brings some interesting information on that kind of situation. And I think like collectively, maybe we don't standardize the way we pull out samples so much. I mean, I know we talk a lot about when to take the sample at the end of a dialysis treatment to calculate our URR and things like that. But what about when you're measuring dialyzer clearance by taking a pre and post dialyzer sample? What about if you try to measure your saturation ratio on your CRT platform by taking an effluent sample and a pre-filter sample? So that paper actually came out, so I think it's 2024 in blood purification. And the point of the paper was to say that for good quality insurance during CRT treatments in people, it was recommended to monitor the dose that you deliver during the treatment, meaning that if you set your machine to deliver a 25 mil per kg per hour treatment, for example, because that's how CRT is prescribed in people, well, you should take some blood and effluent sample during your treatment to check that you're actually delivering the prescribed dose. And if there's any discrepancy, try to adapt your prescription and understand what's happening within your circuit. So that was the starting point of that paper. And what they did is they actually set up an in vitro experiment to simulate a continuous venous hemofiltration treatment on a Prismaflex. They took a circuit that is very familiar to us, VHF20, that we all love for our small patient, and they kind of took just a patient solution. So their goal was to simulate a 70 kilogram patient, and they did that by just taking 3 liters of deionized water, and they dissolved 3 grams of urea within that, what we would call a skippy in that medicine, but they don't have a fancy term like that in people. So a skippy is about 3 liters with 3 grams of dissolved urea, and they don't give much detail within the paper that they claim that during the treatment, they're actually trying to maintain the concentration of urea within that solution constant, 100 micrograms per deciliter. But whatever. So that's your setup. And during that treatment, they're going to look at different blood flows. I think they're going to run at 80, 120, and 160 mils per minute, and different replacement flows. So it's post-filter replacement. And they're looking at some kind of like standard doses in people, which are 15, 20, and 25 mils per kg per hour, which in that simulated patient would correspond to 1,050 meals, 1,400 meals, and 1,750 meals per hour. So that's your setting. And what they did is to look at the impact of how fast you pull out your samples for urea measurement and urea kinetics. And for that, they actually took samples pre-filter, post-filter, and on the effluent side with some motorized 3-channel syringe pump. So the samples will really be collected at the same time with a very controlled speed. And the 3 speeds they were looking at were 1 mil per minute, 2.5 mil per minute, and 5 mil per minute. And when I looked at that, I was just like, wow, well, I mean, even 5 mils per minute, it means that if I was taking a 1 mil sample, it would take 12 seconds to do that. I'm not sure that I'm actually sampling that slow when I'm monitoring my treatment. So I thought it was interesting. And if you think about it, same thing, like 1 mil per minute, which one of us took 60 seconds to take a 1 mil sample out of the circuit for any monitoring? I mean, if you do, please raise your hand because it was kind of unfamiliar to me. But whatever. So the question then was just like, well, okay, you're taking those samples at different speed. You might get some different concentration of urea, but how do you know which one is right? Like which one? How do you know if your results are proper or are not? And the way they chose to look at that, I thought was really interesting as well, because they decided to look at mass balance and mass balance error of urea throughout their hemofilter. So the principle is pretty simple. If you think that we're looking at post-filter replacement CVVH, the mass of urea that is going to get into the filter is pretty much your blood flow times your BUN concentration pre-filter. And you don't have any dialysate going around, so the only thing that's going to come out of your dialyzer is your ultrafiltrate from conductive clearance. And so all the urea that you're going to remove is going to be in that effluent, and the mass of urea you're removing equals the effluent flow times the concentration in the effluent. So you can pretty easily measure how much urea you remove instantly. And then, well, the mass of urea post-filter, it's the same principle, except that you need to take into account that your blood flow is not your nominal blood flow, but it's your blood flow minus your effluent flow, because you actually push some volume through that membrane with hemofiltration. So if you're running at 50 mils a minute and your, let's say your effluent flow is 300 mils per hour, you're pushing 5 mils per minute of plasma water. So your flow at the exit of a dialyzer is only going to be 45 mils per minute. I know that's clear for everybody. So once we got that in mind, well, it seems like obvious that there's no generation of urea. Urea is not going to dissipate in thin air either. And so the mass of urea that you get at the exit of a dialyzer has to be equal to the urea entering the dialyzer minus the urea that left into the effluent. And so you can rearrange that equation to say, well, the mass of urea pre-filter minus the urea post-filter and the urea in the effluent should be equal to 0. And that's your mass balance, right? And so you can rewrite that equation with the concentration and the flows, just like we saw previously. And the way they decided to look at that is like they would take those three samples and they would calculate what they call the mass balance error, which is basically all these concentration and flows divided by the concentration pre in the blood flow times 100. And so if your mass balance is exactly on spot, your mass balance error is going to be 0%. And they considered that the samples were perfect if the mass balance error that they calculated was within a 5% difference. If it was 5 to 10, then they would say it's correct. And if the mass balance error was more than 10% or minus 10%, then we would consider that the sampling was incorrect. So I thought also that it was a pretty smart way to look at that. If the concentration in your samples was appropriate, is to look at where did my urea go, and if you're missing some, or if you have more than you had at the beginning, then you know that you have a problem. And here are basically the results of the study. So it's kind of a busy graph on the left, but basically your y-axis is your percentage error of mass balance. You've got your QB as an X and your Q effluent as a Z-axis. And then the different aspiration velocities are color-coded in green, blue, and red, with the lowest aspiration velocity, 1 mil per mil, being in green and the highest being 5. And as you can tell from the graph, if your effluent flow is 15 mils per kg per hour, whatever your blood flow or your aspiration velocity, your mass balance is proper. So that would be these three lines in the front of the graph. And that's what you would find in that very far right column right there. And as you increase your effluent flow, you'll notice that you start to have like some pretty significant mass balance error, up to 35, 40%, or even almost 50% mass balance error if you're running at slow blood flows and you're aspirating at 5 mils per minute. And I know that 5 mils per minute may seem a little high, but I'm pretty sure that I'm using those kind of aspiration velocity pretty frequently, because that's taking a 1 mil sample in 12 seconds. So think about it. Are you actually taking more than 12 seconds to aspirate a 1 mil sample? And so that's what's translated in that table right there, where at the lower blood flows, which to be fair, we're using pretty often in that medicine, 80 mils per minute is not unfamiliar, especially on an HF20, which we usually don't use above 100 mils per minute. Well, if you're aspirating too fast, even with some effluent flows that are not like crazy, you might have like results that are completely out of whack, and you might not understand what's happening in your circuit. And with the Carpe Diem that has even like smaller filters and lower velocities, I wonder if that's just what happened to that particular colleague, because he was having actually a higher BUN in his post-filter sample than pre-filter. And I wonder if it's just the impact of aspiration velocity when he was taking the samples that could have explained that kind of situation. And one of the other results that they were showing in the study was actually the disruption of the arterial, pre-filter, post-filter, and effluent pressures by the sampling. And you can tell from these graphs, like each time you're actually pulling a sample, you've got a pressure drop that can be like 20, 40 millimeters of mercury almost. And those pressure drops are going to be more pronounced the higher the suction velocity, obviously, but the impact of the suction velocity is going to be more at lower blood flows than at higher blood flows. And so when you think about it that way, you're applying negative pressure. So what's happening? Well, if you're pre-filter, you might actually suck some blood that was already in your filter back down, and with a lower BUN concentration, and you might dilute your pre-filter BUN. If you're post-filter, how can you be sure that you're actually getting a sample that is coming out of the hemofilter and that you're not suctioning from your venous chamber, for example? Or are you actually sucking blood out of the dialyzer faster than it should, resulting in maybe not as much urea clearance as you should have had? Uh, the other thing that can happen is conceptually, you could imagine that by applying negative pressure post-filter, you might be sucking back some effluent through the membrane, and that way getting back some more BUN on that side of the membrane while you're still sampling your effluent a little bit further into the circuit. So there's a lot of reason for error there. The author mentioned also that on the effluent line, you could be um, by by applying negative pressure on the effluent side, you could have more ultrafiltration, more convection. However, I feel like, especially on the Prismax of the Prismaflex, the effluent sampling line is after the peristaltic pump. So I don't think you can have that much of an impact. But if the sampling port was between the exit of the hemofilter and the peristaltic pump, then you might have an impact on that. So the conclusion of the article was that, well, if we're looking at the effective delivered dose compared to the target machine dose, well, if you were using an aspiration velocity of 1 ml per minute, you were pretty much on par, whatever was your blood flow. But you could actually overestimate the delivered dose if you were using higher aspiration velocity. And that effect would be even more pronounced at slower blood flows. So I don't think it's that much that application that I'm interested in that medicine. But I was thinking like pretty regularly when I'm starting a treatment, and maybe my dialysate flow is higher than I would like compared to my blood flow. I like to measure a saturation ratio. So the ratio between my effluent BUN and my BUN of blood entering the hemofilter to know if I exactly get 1 ml of clearance per ml of effluent or if I need to apply a correction factor. And definitely when I do that, aspiration velocity could have an impact. And I'm definitely going to look at that a little bit differently. And it seems like the safe aspiration velocity would be 1 ml per minute, which seems like watching paint dry. So it might be a little bit difficult, but I think it was kind of eye-opening and might actually bring some answers to that question, like what is happening with my carpe diem? Why do I have a higher BUN concentration post-filter than pre-filter? So there you go. So mass balance error increases as suction velocity increase. It particularly impacts mass balance at lower blood flows and higher effluent flows. And we can explain that because of the impact of aspiration velocity on the extracorporeal circuit pressures. So yeah, I would be curious to know, what are your thoughts on that topic? And is it something that you ever thought of while you were sampling your extracorporeal circuit? Um, I just thought it was a little bit of a niche topic, a little detail, but devil lies in the details, as we all know. I think you're muted, Dr. Cargill.
What explanation would you give for why he might have been getting a post-filter value that was higher than the pre-filter value?
Well, I wonder if it's the retroaspiration of some of the effluent through the membrane. If he is retrofiltering some effluent, that would be my only explanation.
But
Uh,
the concentration in the effluent wouldn't be greater than unless
no,
there was
but
a big
but
time delay.
yeah, well, time delay or just like you're sampling your effluent. So first of all, the carpe diem, and I'm not very familiar with that machine. I never used it. The one thing I know that is pretty peculiar about that machine, except for the small size and low flows, is that the dialysates and the blood are not countercurrent. They
Mm.
follow the same flow, which is
Mm.
kind of interesting, I think. Uh, And then when you're sampling your effluent, I suspect that you're sampling the effluent like further from the filter. And so you might have a concentration there, and by sucking some effluent back, I mean, I don't really understand how it could be higher, but I think that could be one of the explanation. Like there's an error in mass balance because of the aspiration velocity.
I could understand the error in math balance, but I can't quite grab how that post-filter sample would be higher than the pre-filter sample.
Yeah,
Uh,
but I
Unless,
think
go ahead.
I think if you look at that, because like for example, look at that part of the graph right there. Uh,
Mm,
I mean, they have some mass balance errors that are actually positive,
mm.
meaning that if you add up all of the BUN concentration and flows, you actually have more BUN at the end of the day than you had previously, right? If the mass
Mm.
balance error is positive. That's why I was like kind of surprised. So I might have to dig a little bit more into that, but if your mass balance is positive, that means that that term is no. So yeah, no, actually that doesn't work. What I'm
It
saying.
has to be negative. It'd be a
Yeah. So,
negative.
but they also have some negative ones, like a
Yeah.
few. I mean, they're more discrete for sure, but
Um,
like for example, that one is a negative one, meaning that you may have some more post or more in the effluent than
I
you were
I
supposed
could
to.
I could imagine some negative ones or some error just because of lab lab analytical error
Yeah,
or pump error, pump flow error, those kinds of things. Um, but it is kind of difficult to understand how you would
get more. Yeah,
get more. Yeah, that's curious.
but what's interesting too is that you can tell that like s- most of the time you're kind of within the ballpark, and I think that's why they accept like that 5 to 10% mass balance error to take into account like analytic.
All those errors. Yeah,
Yeah, but you can really tell that it's just like, okay, well, when we get to that kind of effluent flow, now the 5 mils per minute just spikes at low blood
hmm
flows. And then when you get to the next stage, and okay, now even the 2.5 impacts. So I mean, it shows really nicely that yes, like too much suction is going to disrupt your extracorporeal pressures, and that if you're really running low flows, that you're actually going to impact more.
yeah,
What I wasn't, what I was expecting too is that it would impact more the slower blood flows, like 80 mils per minute, more than 120 or 160. That kind of makes sense. What I was not expecting is it actually impacts more the high effluent flows than the slow effluent flows.
yeah. I would suspect that you're actually aspirating back some of the effluent. Yeah.
Yeah. So that's my feeling. Um, but anyway, I mean that's a paper that I did see, but went a little bit under the radar. But after that question in the email, I was like, wait, I saw something about that that could be part of the explanation, and I thought it was an interesting topic to bring up because I'm pretty sure nobody uses either a controlled syringe to take samples, but also we're not taking that much time. I mean, when I get a zero point 0.5 sample or 1 mil sample, I'm probably pulling that out like what 3 to 5 seconds, maybe.
But this brings up another important point, and that is standardizing our sampling, and I'm thinking particularly the post-treatment sampling. And if you don't standardize that post-treatment sampling to something that's universally defined and accepted, and usually, if we use the KDOQI guidelines, you drop the blood flow to 50 mils a minute or something really slow, and you take the sample within 10 or 15 seconds of stopping the treatment. But if you wait even just a few minutes after the end of the treatment to take that post-treatment sample, you already have rebound, and it'd be very difficult to compare data or or laboratory information or center to center information without standard, like one center getting your reduction ratios of X and another one getting reduction ratios of Y with the same treatment might be entirely dependent on sampling error or the time of sampling error. And for somebody who's done a lot of urea kinetic analysis where you just have to be very precise about all of your measurements and sampling, and there are a lot of measurements to do when you do true urea kinetic analysis, you really introduce a lot of errors unless you do things very precisely. But particularly that post filter or that post treatment sampling, and we're not plagued with cardiopulmonary recirculation like they are in human patients, but certainly rebound is a very rapidly acting force, and also you could have errors from and it just flew out of my head the other but that's an important thing to standardize in your unit. And I don't know if that got into the guidelines, the IHD
Yeah,
guide.
I was thinking about that. I can't remember on top of my head. I know that our standard procedure in San Diego, and probably it came from Davis initially, was to put the patient in bypass, lower the blood flow to 50 mils per minute, I think, wait 30 seconds and take the sample. And all of that obviously before rinse back. So it's not like we rinse back the patient and then we take a sample. It's at the end of the target treatment time or dialysis time, we just like put into bypass, lower the blood flow, take our samples, and then while we're actually taking the sample for the lab, we will start to rinse back the patient and go back, which um, and I think when we got the Prismax in the service, that's something that we try to replicate. Like even for Prismax treatment, I tend to take my samples. I'm going to pull out the dialysate to 0 mils per hour, the replacement to 0 mils per hour. I have no ultrafiltration, lower the blood flow, and wait a similar amount of time before I take my sample, which kind of like took a while to get used to. Um, just like the fact that when you're doing your treatment on the Phoenix, you're going to get that little alarm like 30 minutes from the end of your treatment to tell you, hey, you can shut off the apron. And I realized that more often than not, we might forget to discontinue heparin before the end of our Prismax treatments if we don't pay attention. But I think it's also like a good point that not only in between units, but within your unit between different treatment modalities, trying to standardize the sampling as much as possible is paramount for if you want to compare like the dose of dialysis delivered between treatments. But I suspect that aspiration velocity does not impact those post-treatment samples so much. First of all, because we're not sampling pre-filter, post-filter, or effluent. We're resampling from the patient at the catheter, like closer to the catheter. And so, I mean, unless you're really aspirating with a big syringe and taking a big sample, I don't think you're disrupting your blood flow. Let's say you pull down the blood flow to 50 mils per minute. Even an aspiration velocity of 5 mils per minute is less than 10%. So that should be fine. I mean, I don't see any reason you're not going to get any recirculation from your catheter because you actually discontinued dialysis 30 seconds ago. So you're not going to get that in the way. So yeah, that matter of aspiration velocity, I don't think impacts the post-treatment so much, but more like during the treatment sampling.
Yeah. I would suspect that aspiration velocity will come into more significance with the use of these tiny filters. I would suspect if they used an M60 or a bigger an HF 100 or something, that their errors would be smaller.
Yeah,
Tiny
I was
filters would do that. One other point.
I was actually really surprised because like I mean they're using HF20, but then they're running at 120 and 160 mils a minute. I didn't think you could do that. I
Yeah.
thought you get you get stopped at 100 mils per minute. Um, and same thing. I mean, the experimental setup is a little out of reality. Um, First of all, because yes, they're using a tiny filter, they're running blood flows that are not planned to be in that dialyzer. Like 160 mils on an HF20 is not, it's not designed to handle that. The other thing also is I was looking, it's kind of interesting because I was kind of like, okay, you're doing only hemofiltration and you're running 1750 mils per hour of effluent. I mean, it's not unheard of on an HF20. I mean, I've done that multiple times, but not with post replacement hemofiltration. Because if you look in detail, that gives them like a filtration fraction of about 40%.
Yeah.
So, and I wonder also if it's the reason why the mass balance is more erroneous at high effluent flows, because they have a filtration fraction that seems like very excessive. Um, they justify the fact that they use deionized water with dissolved urea and not blood, because they didn't want to have any um, viscosity errors or fouling of a membrane during the treatment between the beginning and the end of the treatment, things like that. I think to be fair, it's just easier to get water with dissolved urea than blood to run those in vitro experiments. But again, so like all of these results are to take with a grain of salt, and I'm not saying that I'm not going to aspirate any more than 1 meal per minute when I'm sampling now, but I just think it brings that idea out there. Like if you're sucking too hard on your circuit, you might disrupt the circulation of blood and effluent, and you might have some mass balance error. So if your results do not make sense, maybe sample again with a gentler aspiration to make sure that that's not the cause of your problem.
I think that paper, even though the methodology might not be reality, but I think it brings up those concepts very nicely and demonstrates those concepts very nicely. I mean, probably most of you have had the the experience where you can sample and get a pressure alarm just from sampling.
Yes.
And so that tells you that you're aspirating too fast.
They actually report that in the paper.
Oh,
That
do they?
I've had slower blood flows and 5 meals per minute aspiration. They had some alarms every now and then.
I wanted to make two other points. One point was that in again in regard to post treatment sampling, if you took your samples after rinse back, there's probably 15 or 20-minute delay between the end of the treatment and when you would take your sample. By that time, you probably have already increased the BUN concentration by 25 or 30%. And so your clearance and your reduction ratios are going to be much they're going to be very skewed and predict a much less efficient treatment than you may have actually delivered. Um, because that rebound is very quickly. You come into almost 100% reequilibration within about 35 or 40 minutes. And so you can imagine that, at 15 or 20 minutes, when that curve is pretty steep, that you've really increased the blood concentration of urea artificially. I mean, you get a better reality of the actual treatment you delivered to the patient when you sample later, but you can't really compare your treatment efficiency
You
from one
cannot look
treatment
at your
to the
single
next.
pool kinetic.
Right.
Your single pool kinetic has to be with the post-treatment sample that is immediate. It's more if you want to look at your KT over V at equilibrium, but you need to delete sample. The other thing that I think we underestimate sometimes is the impact of the circuit size and volume on the patient BUN concentration for very small patients. And that's something that I've seen when I was kind of like trying the calculator with smaller patients like cats. And in cats, even if you're using the smaller circuit, I mean, your HF20 circuit is about 60 mil. But if you think about it, your patient blood volume can be 240 to 300 mils. So those 60 mils are not exactly neglectable. And what happens if you measure BUN during your treatment is you're going to realize that at the very beginning of your treatment, if you take a sample right before you start the treatment and a couple minutes after, just the dilution by the prime is going to take your BUN down a few points. And I was kind of I noticed that because when I was following those treatments in these cats, I my 1 hour, 2 hour, 3 hour, 5 hour samples were always a little lower than I expected based on my calculations. But the slope of decline was exactly parallel to my prediction. And I realized that actually the difference with that little dip at the beginning, and if you correct your starting BUN concentration by the dilution factor of the size of the circuit compared to your estimated patient blood volume, then the lines were exactly one on top of each other. And so it's the same at the end. Like I suspect that um, if you're taking your post-treatment sample on a cat, and let's say that you could just clap your hand and the cat would be immediately rinsed back, you would still see a little dip because of the dilution. Um, so it wouldn't be as impactful at the beginning of the treatment because obviously at the beginning of the treatment, you're diluting because the B1 in your circuit is zero, which is not the case at the end of a treatment. But you kind of changing the blood volume a little bit, so that can also come into account at some point.
One other point that I wanted to bring up, because I've had the opportunity to look at it, if you're using an HF20 or even probably more so on the Carpe Diem where you've got, or on the VetSmart machine where they have these tiny little filters, that if you're doing post-filter dilution, um, the well, maybe regardless of what kind of dilution you're doing, if what we're taught is if the QB QD ratio is greater than 3, that you probably have 100% saturation of the effluent. That is not true on those tiny filters, and sometimes it may take a QB QD ratio of 15 or 20 in order to get saturation, 100 complete saturation, depending on the effluent flow rate. And I think that doesn't get taken into consideration when we're predicting the treatment efficiency using those tiny filters.
Yeah, and that's why I usually recommend like I think it's always interesting within the first 30 minutes of treatment to measure a saturation
Yeah,
ratio
I
and to
agree.
make sure that we're actually on par with our expectations. And it's as easy as taking an effluent sample, a pre-filter sample. It's just 2 point BUN. It's very easy to do, and I think it gives great insights. Because all of a sudden, if your saturation ratio is 80%, well, maybe you need to consider to prolong your treatment if you're doing PIRT, or maybe you actually have to increase your effluent rate, which might sound counterintuitive because if you increase the effluent rate for the same blood flow, your saturation ratio might decrease to 75%. But 75% of 3 liters per hour might be better than 80% of 2 liters per hour.
Mhm.
So there's a lot of manipulation and calculation you can do to make sure that you're actually delivering the clearance you want to achieve your end treatment you are on.
And maybe finally, it's important to actually measure the efficiency of your treatment, even if you're just doing pre and post treatment. I would imagine that there would be
Well,
centers where they just presume, this dose of these machine settings, and not bother to get all of those samples just to reduce cost.
Well, the other situation where I feel like I've measured saturation ratio in the past, and that can be interesting, is if you're running an HF20, again, it's a very tiny dialyzer, and we usually running it to its limits, right? So if your saturation ratio is already, let's say, 90-95%, you're getting a pretty efficient treatment, but you don't have any reserve like you would have with a bigger hemofilter.
Mm.
And what that means is that if you have any clotting during your treatment, that saturation ratio is going to plummet because you have less surface area for exchange. And so with the same effluent flow and blood flow, um, you might measure the saturation ratio in the first 30 minutes and have 95%. But maybe 3 hours into your treatment, that saturation ratio has dropped to like 65 or 70 because of clotting. And if you don't realize that, the outcome of your treatment are going to be disappointing. And very similarly to monitoring ionic dialysate on an IHD machine, where if you see that your ionic dialysate is turning down, that can be a sign that you're clotting your dialyzer. Um, I think that monitoring the saturation ratio during a PIRT treatment might be also a way to monitor for loss of efficiency and maybe clotting of your filter. Um, and especially if you start to see those little uptrend in TMP and delta P, it might be interesting to say, hey, if those pressures are going up, it might be clotting. And not only do I have to adjust my anticoagulation, but maybe I also have to adjust my treatment prescription or check for treatment efficiency.
Mm.
So that's the other way that I'm using saturation ratio every now and then is to monitor for clotting of my filter.
We probably have everybody's eyes glassing over now. I've watched a few people log off of the meeting. So
Well, it might be a little harsh to start with, but
the
I mean,
urea kinetics always kinds of turns,
yeah,
turns
yeah,
everybody to sleep.
turns
Cedric,
people away. Yes.
you got a question in the chat from
Yeah, I
Jenna.
was just looking at that right now. So, does anyone know what is accepted variability of BUN on a chemistry analyzer? I do not, on top of my head. Um, I guess that it's going to depend a lot on the technique that they're using and on the analyzer. Um,
Well,
I
I know
gotta,
for creatinine because we've studied
yeah,
that.
for the critical
For
difference.
creatinine, it's point 0.3 milligrams per deciliter. And for human labs, they sent out a standard that everybody who's in some laboratory analysis group gets the same standard, and they calibrate their machines to that standard. And you have to be within that zero point 0.3 milligrams per deciliter difference. And that's the reason we've chosen zero point 0.3 milligrams per deciliter as a predictor of acute kidney injury, because that gets you beyond laboratory error.
Yeah.
So I would suspect that it's probably less than 10%.
Yeah, well, what I would point out though is that most of the chemistry analyzers are designed to have a linearity of the technique that is between, for example, for BU, and maybe between 0 and 100 or 130. And when you get past that, which is not uncommon in our dialysis patient, I'm not sure you can the measuring technique is reliable anymore. And that's why some of your analyzers are actually not going to measure it and tells you what it's more than 130. And when that happens, you have to rely then on diluting your sample, which actually increases the margin for error by a lot. Because first of all, your dilution might not be exactly 142 or 144. And then if you say, well, let's take creatinine, for example, let's say that within the interval of linearity, your error is 0.3 milligrams per deciliter. Well, it turns out that if you dilute your sample by 4, and you use a diluted sample to be measured, then the result, I mean, that 0.3 is going to, the error on the diluted sample is going to be 1.2 now. Because you can have that 0.3 error, and when you multiply the result by 4, it's 1.2. So, I mean, the absolute value of error is interesting. I think that the percentage error is interesting as well. And we have to remember that if we use dilution, then we might have a lot more problems there. So that's why I feel like, especially if you're designing an in vitro experiment, like the one we discussed today, you need to stay within the margin of what your analyzer has been calibrated for, and not over that, because then like you're inducing more error in your measurement. But bottom line, no, I don't know what is the accepted viability of BUN, but it's probably plus or minus 10%. I would suspect, or even less than that.
Thank you. I appreciate those thoughts. And I was just wondering, with some of, with some of the previous backgrounds and, what initiated this conversation, if some of these errors, and which has been mentioned, but really, particularly if things aren't idealized for these patients, if that could actually account for some of the mismatches between what is anticipated and what is actually obtained at patient bedside. I mean, the other thing is if we're doing bedside measurements, depending on where you are and how good QC is, I mean, that can be a huge issue as well. And depending on the modality used, if it's not run by, an external validated chemistry analyzer, if it's a bedside machine, I have found those to be extremely variable in some of the BUNs and creatinines obtained. And so I do wonder if some of that could be influencing some of these weird results that you alluded to.
Yeah, agree. I think at the end of the day, it also boils down to what are you trying to achieve with those measurements? Like there's either you're in an experimental setting and you're trying to do very precise urea kinetics, and then you really have to dig down on those like confounding factors. My feeling is that when you're actually treating a patient and you just trying to get an idea what you're doing, and I don't care so much about a small variability in my results. And especially if you're using the same analyzer for all your samples at the same time on the same lot of slides or regions and things like that, you're still gonna have an idea what's happening. So that's my feeling. I feel like sometimes we are like we tend to discard, say, well, I'm not doing that because there's like too much variability or whatever. Yes, maybe to publish a paper on your kinetics, but maybe it will still give you some valuable information on the patient you have on the table right now. But we still have to keep those limitations in mind for sure. So Dr. Luswer is posting that 3 to 7% is the variability from the analyzer, and the biologic variation would be 15 to 20% in dogs, 12 to 18% in cats, with a paper attached. So for sure, we see that a lot. I mean, even if you take the same sample and you run it like 3 times in a row in your analyzer, you're going to get some different results anyway. But to go back to the initial discussion, it's still very weird to get a higher BUN concentration post-filter than pre-filter when you're doing a treatment. And that has to be more than analyzer variability, I would guess. But that could amplify the problem for sure. Does anybody have any other insight on sampling during extracorporeal therapies or such? All right. So as we mentioned at the beginning of the session, and some of you may have not been there, it sounds like Dr. Jethro Forbes and myself are going to be hosting the international renal rounds, at least for the few sessions to come. And I think what we would love is to hear from you and know what you would be interested, what kind of content you would like to see in these rounds. Like, do you like the kind of an open discussion without a plan? Do you want some more formal presentation, paper discussion, and things like that? Because we would like to cater to the audience as much as possible, and try to actually attract more people to these rounds. Because I think we always have some very interesting and eye-opening conversations sometimes. There's always somebody bringing up a little details that I never thought of or something like that. So I feel we're all learning a lot from each other. So please reach out to Summer, myself, or Jethro if you have any idea on that. And
I'm also
also,
happy to send out a little poll, like a quick little survey to
yeah,
the
I was
invite
actually
list if you'd
thinking
like.
about that. The other thing also I was thinking is if any of you wants to present a case or wants to discuss a case, it might not be very easy to sometimes prepare to present for international renal rounds, and then the day of, somebody else brings a topic and you don't get to present your case, and then you just forget about it. And I was thinking that maybe we could like do a little sign up genius where some people could say, hey, you know what? Next time I've got something I want to discuss, I've got a case I want to present, and they could just sign up, and that way Jeffrey and I would know if somebody has something to bring up, and if not, we'll prepare something on our side. But I think that could be interesting if people could say, hey, if I really spend some time preparing something to present, that I will have a shot to do it on these rounds on that day. So anyway, let us know. We'd love the feedback to make these sessions as interactive as possible. The goal is that I don't need to speak, and Jeffrey doesn't need to speak much, and you guys are bringing up the topics. All right.
Thank you so
Any
much.
any closing remarks, anybody? Okay, well then I guess we can stop the recording, and we'll see you all in 2 weeks.
Have a great weekend.
Bye.